Hi, I'm Roy Dahil, a BS Public Health graduate of UP Visayas and currently taking Masters in Health Informatics. For our class in Coding and Classification and Terminology in Medicine, I'm going to discuss with you the coding and standards used in PhilHealth. To facilitate the discourse for this topic, I encourage everyone to continue our discussion online through YouTube or Twitter. You may follow my Twitter account at rdahildahil_, or you can use these hashtags in the corner of the screen if you have comments about my presentation. First, I will start with a short clip from the PhilHealth to briefly discuss with you what PhilHealth is all about. The video is courtesy of Team PhilHealth.
I began in the 60s when a group of doctors saw the need to provide free healthcare services to the less fortunate. From a small community, I have evolved into a national health insurance program that embraces everyone, especially those who need it the most: the sick, the elderly, the poor. Since then, I have opened the door for partnerships with healthcare providers, sponsors, and stakeholders. I am driven. I reach out to every Filipino, even to those beyond our shores. Each day, I deal with people from all walks of life, each one with his own unique story, but with one desire: that should any of their loved ones need medical attention, I will be there to provide financial risk protection. Because it's not about the benefits nor the contributions, but about people wanting life to go on, being well again. I am PhilHealth. I am the only health insurance program that includes everyone, that excludes no one. Beyond that, I have a heart for the less fortunate. As a financial institution, I am inclusive, an advocate of social solidarity, where the healthy subsidizes the sick, the young for the old, and the rich for the poor. I am PhilHealth. I am for every man, woman, and child, whether rich or poor, from here or abroad. Because no individual should be denied healthcare just because they lack the means to cover it. In a sense, I am like your parent, who is there for you every step of the way, who listens, who cares, who nurtures. I will always be there for you. You are the reason for who I am and who I can still be. I am PhilHealth. I stand for the right of every Filipino to have the means to avail of healthcare services, to alleviate their financial burden in one way or another, to assist, to counsel, to guide. I am PhilHealth. I secure, I cover, I protect.
The call to serve the rural indigent started as early as 1960s when the Philippine Medical Association introduced the Maria Project, which prioritized aid to communities in need of medical assistance. This was a valuable precursor to the Medicare program, from which a medical care plan for the entire Philippines was created. Then, in August 4, 1969, Republic Act 6111, or the Philippine Medical Care Act of 1969, was signed by President Ferdinand Marcos, which was eventually implemented in August 1971. The objectives of the Philippine Medical Care Act are the following: extension of medical care to all residents in an evolutionary way within our economic means and capability as a nation,
providing the people of the country a practical means of helping themselves pay for adequate medical care, and to establish a medical care commission, the Philippine Medical Care Commission, also known as the PMCC. The PMCC was tasked to oversee the implementation of the program, which went for almost a quarter of a century.
The vision in the 1990s was to have a better, more responsive government healthcare program. This was prompted by the passage of several bills that had significant implications on health financing. During this time, public demands a more comprehensive healthcare plan in terms of covered population and benefits, which led to the development of House Bill 14225 and the Senate Bill of 01738. This became the National Health Insurance Act of 1995 or Republic Act 7875, which was signed by Fidel V. Ramos on February 14, 1995. The law paved the way for the creation of the Philippine Health Insurance Corporation, also known as PhilHealth. This mandated to provide social health insurance coverage to all Filipinos in 15 years' time. As we all know, the benefits Filipinos get from the PhilHealth as the Philippine Health Insurance Corporation is that it compensates expenses incurred by the Filipino with regards to their hospital and other health needs. So how does the PhilHealth compute every Filipino health expenses? In Section 43 of the Implementing Rules and Regulations of the RA 7875, it states that a member only needs to submit an official receipt or any proof of payment and or statement of account issued by the health institution. The benefits to be granted shall be paid to the member in the equivalent local rate based on the Level 3 hospital category. And the problem here is that local hospitals may not have the same rates for every procedure. So in order to address this problem, where providers do not agree with a specific provision of issuance, rates paid for services rendered, for example, relative value scale was implemented.
In early 90s, USAID funded a study through PhilHealth's Health Finance Development Project to update and revise the 1972 Relative Value Scale. In 1995, this RVS was completed and was used as the basis for the compensation of professionals.
In the PhilHealth Board Resolution number 43, Series of 2001, Relative Value Scale or RVS was implemented for the purpose of standardizing payables. So in essence, physician will be paid a standard and specific amount related to the procedure.
While RVS was used to standardize procedures, ICD-10, on the other hand, was used to standardize reimbursable for the medical conditions. ICD-10 was strictly used and implemented by PhilHealth. In the PhilHealth Circular Number 43 Series of 2002, all claims with no codes in the ICD-10 shall be denied and shall be non-appealable. Here is one of the sample forms of the PhilHealth in documenting the diagnosis and the procedures offered to the patient. Notice that the ICD-10 and RVS was used by PhilHealth to standardize the terminology of the diagnosis and the related procedures.
An RVS is a systematic listing of surgical, medical, and diagnostic procedures and services, the corresponding 5-digit code, and relative value unit or the RVUs. According to the RVS 2010 manual, most of the procedures there are listed with permission from the current procedural terminology of the American Medical Association.
The RVS standardizes terminology for procedures. This was adapted from CPT, basically to assign monetary value for each procedure. In the RVS manual, it is arranged such that the descriptions are standalone or complete by themselves. Here is an example of an RVS as presented in the RVS Manual 2010. The first column is the 5-digit RVS code. Second column are the procedures. Written in bold are the lead terms, while listed below it are the specifics or modifiers under the same lead term. The last column is the corresponding relative value unit or RVU. Relative value unit or RVUs are determined based on the difficulty of the procedure. In essence, procedures classified as catastrophic cases will have an RVU value of 201 and above. Intensive cases will have RVU values from 81 to 200, while ordinary cases will have RVU values from 80 and below. The RVUs for these procedures were all determined by the PhilHealth for purposes of computing for professional fee reimbursements. Compensation is computed by multiplying the RVU by the peso conversion factor or PCF, which was set before to 40 pesos. So for example, a splenectomy with RVS code 38100 for total splenectomy was assigned an RVU value of 160. Multiplied by the peso conversion factor of 40, the computed amount for the procedure would be 6,400 pesos, while for partial splenectomy, the computed amount will be 6,000.
The RVUs for these procedures were all determined by the PhilHealth for purpose of computing for professional fee reimbursements. But as we all know, there were a lot of procedures that were added by PhilHealth that were not originally in the CPT. Additions were included by PhilHealth for the reason that these procedures are deemed reimbursable.
RVUs are also being used in many ways. One is to classify the procedures in order to determine the payment for the operating room, which by the way varies per type of hospital. Here for example, for RVU 30 and below, maximum operating room fee for primary hospital is 385 pesos, while for secondary hospital is 670 pesos, and for tertiary hospital is 1,060 pesos. RVUs can also be used to compute the compensation of the anesthesiologists and of course the surgeons. And further, RVUs can also be used to control what procedures are allowed or accredited for a certain level of healthcare institution. Amendments to the RVS are continuously updated through PhilHealth circulars. In 2008, the PhilHealth Board decided to consolidate the functions of the Peer Review Committee and the RVU Oversight Committee into one committee called the Quality Assurance Committee. The membership of the committee is composed of representatives from the Medical Specialty Societies, Board of Medicine, Professional Regulation Commission, and the Philippine Hospital Association. The Quality Assurance Committee shall retain the function of reviewing and updating the existing relative value scale. Since its implementation, there have been many circulars released by PhilHealth regarding the RVS and other standards. In 2012, PhilHealth released a memo that they will be adopting LOINC, or the Logical Observation Identifiers, names and codes for laboratory and other clinical observations.
That's all for my lecture in Coding and Standards in PhilHealth. If you have any questions or comments, feel free to tweet using the hashtags or comment in the comment section below.